this is in two parts, and I'm going to kick off, and then Vesna will follow. And the session will last, well, it's supposed to be about 90 minutes in total. And what I'm going to do is talk a little bit about the NHS England haemoglobinopathy developments. Then we'll talk about the biology and so forth. I'll talk about the unusual hemoglobins and the newborn results, and how you would explain genetic inheritance, and ill health prevention, community care. Vesna will go on to talk about that afterwards. So some years ago, NHS England decided that they would look more seriously at how haemoglobinopathy services are provided in England. So back in 2017, they contacted all those who provide services, and they did a review. And they then came up with the idea of the improved specialized services for England. This is NHS England only, even though Scotland and Wales and Northern Ireland are doing their thing. But what we're talking about today when we talk about the HCC is NHS England. So in November 2018, they did a review of services. And they came up with a number of developments. Now, we always had local providers, so they will continue to deliver all aspects of services, but they'll be able to access more support. Prior to the review, a number of areas, up to about 70, 90, were considering themselves as specialist haemoglobinopathy teams. What NHS England then did was to do, after the review, was to designate specific areas or specific services as specialist haemoglobinopathy teams. These are hospital services. And then they were funded to undertake specialist activity. So at the moment, we now have 24 specialist haemoglobinopathy teams. Then the newly commissioned aspect is the haemoglobinopathy coordinating centers, of which are there 10 for sickle, and ours being one of them. Ours is the West London haemoglobinopathy center, and then 4 for thalassaemia and rare anemias. And these are funded by NHS England to oversee services within their region and to provide support to the LHTs, and also education of health and allied professionals. The other aspect that's newly commissioned is a National Haemoglobinopathy Panel. And King's College Hospital Foundation Trust is the one that has been given that NHP. And the NHP is really to look at the national picture of haemoglobinopathy services. So, you know, they oversee, for example, very specialist and complex care needs. For example, they will determine who should go for bone marrow transplant or gene therapy or novel treatments. Prior to even the development of all this, there were the Haemoglobinopathy Networks. And NHS England then tried to unify some of these networks so that they will be able to look more closely at the services within their own specific locality. So these networks are to help improve services, to provide education, to involve users, and to support the two screening programs, which are the antenatal and the newborn screening program. Also, they were to maintain and enable the development of a national patient register. Some areas already had a register, some areas did not. But, you know, but they managed to, those who did not, they were able to provide them with funding to be able to develop a national haemoglobinopathy register, and then to promote research and access to clinical studies. So this map gives you an idea of the number of sickle cell HCCs in England. And we are part of the West London HCC, which is made up of 3 SHTs. That's Imperial NHS Trust, who are the lead, and London Northwest NHS Trust, and St. George's NHS Trust. So between the 3, we make up the West London Sickle Cell HCC. Okay, so we'll go on to sickle now. So sickle is a condition of the bud that's passed on from one generation to the other through the genes inherited from both parents. It's not catching, it's not discriminating. Unlike some myths and misconceptions, it's not due to witchcraft. And you'll find a lot of societies, a lot of cultures still believe in witchcraft. And unfortunately, these are the same cultures that tend to have sickle. So it's a global condition. You see it anywhere in the world, but the areas where it's most common, you will find are mostly areas of the world where malaria was or is endemic. So you will find sickle in a large proportion areas of the world. You'll see it in Western or Northern European areas because of migration, but I'll talk a little bit about that in a moment. But just to emphasize again, the whole notion of witchcraft and belief in supernatural forces is something that one needs to consider when one is talking about hemoglobinopathies, and particularly about sickle cell. Because you'll find that Western cultures tend to attribute illness to one of several factors, and most of it are biological. But many non-Western cultures attribute disease to other agents, including supernatural belief in evil forces and witchcraft. So when you're dealing with communities where hemoglobinopathies are common, you need to have that at the back of your mind, that there are populations of society or that you're dealing with may have other values and beliefs that you may not share, but which will have an impact on their attitude to the illness and their acceptance of prescribed treatments. So in terms of the hemoglobin, when we're talking about sickle and thalassaemia, it takes us back to our very early days of nursing, for those of us who are nurses. We're talking about the blood, and the blood is made up of different components. Now, I have to take on board that there are those in this audience who are not, healthcare professionals, so you'll have to bear with me. So blood is made up of different components. You've got the red blood cells, the white blood cells, plasma, platelets, and water, and they all do different things. Red blood cells carry oxygen around the body. White cells help you fight infection. Plasma is the fluid that can, helps carry some of the stuff around. Platelets clot the blood, and you've got some water as well. So normal blood component is able to flow freely within the blood vessels. And the red blood cells are what we're focusing on when we're talking about sickle cell and thalassaemia. The red blood cells are like a donut, but that hasn't got a hole in the middle, but it's indented. So it's very flexible and very pliable. And it lives roughly 120 days in circulation. So we're always making new red blood cells and getting rid of the old ones by the body. So this is what a normal red blood cell looks like. Like I said, it's biconcave, it's flexible. And the molecules within it, which is the hemoglobin, they are free flowing within the red blood cells. And it's these hemoglobin molecules that are involved when we're talking about sickle. So the normal hemoglobin is able to flow freely within the red blood cells, even when it's deoxygenated. So the normal adult hemoglobin, there are certain hemoglobins we have when we are in the womb, which is fetal hemoglobin. I'm not focusing on that at the moment, but the normal adult hemoglobin combination is called hemoglobin A, and it's made up of 2 alpha and 2 beta globin chains. Now, that's when you're an adult, 95% of your hemoglobin is hemoglobin A. There's also a minor type of adult hemoglobin called A2, and we synthesize that in about 2 to 3.5%. And in a normal adult, you'll still see we still have some fetal hemoglobin, but it's less than about 1%. So hemoglobin A2 is not really useful. It's only useful for doing laboratory testing, but it doesn't carry oxygen very well. It's got too many problems with it that it's not efficient at carrying oxygen. So the part of the blood that carries most of the oxygen is this hemoglobin A and some hemoglobin F. So when we look at what is the normal adult chain, your beta hemoglobin, if you've inherited normal beta hemoglobin gene from one parent, you'll have beta hemoglobin A, which stands for adult. And if you've inherited normal from the second parent, you'll have beta A again. We won't talk about the alphas. They're not so significant in the discussion we're doing today. But you also inherit a pair of alpha globin genes from one set from each parent. So when we look at the normal synthesis of hemoglobin, when you're newborn, majority of the hemoglobin is fetal. So when the laboratory is giving you the result of a newborn baby, they'll tell you what they see the highest number of, which is fetal. So when you're first born, your fetal hemoglobin is about 90%. But whatever adult hemoglobin you've inherited from your parents, you'll have about 8% of that, or roughly. And then you'll have some hemoglobin A2, which everybody has, roughly 2 to 3.5%. But you'll also notice that by the time you're 6 months to a year old, there's increasing switchover between the fetal and the adult hemoglobin. So by the time you're 6 months old, you'll have your fetal hemoglobin going down and your adult hemoglobin going up. And certainly by the time you're a year old, the fetal hemoglobin has gone right down to about 1%, while your adult hemoglobin is about 95%. So that process takes roughly about a year. But by the time you reach a year old, that switchover would have been complete. I hope you're still all following me. Any responses?
Yes.
Just checking no one's asleep yet. Okay. So in terms of interpreting the newborn, because all the health visitors get newborn results, and they want to know, how do we make sense of these results? The results you get in the newborn result reporting, you have to remember the newborn screening is for sickle screening only when it comes to hemoglobinopathies. It's not aiming to identify thalassaemia or any other hemoglobin. Those hemoglobin genes are identified just by chance of testing for sickle. So the screening program is purely for identifying children with sickle cell disease, not even the carriers for sickle cell disease. So when you get a result and the result says HBFA, this is possibly a normal result for a newborn, which means that that child hasn't got sickle hemoglobin or any of the other 6 or 7 that we are looking for. It doesn't mean that the child does not have any unusual hemoglobin, because there are over 1,200 mutations of hemoglobin, and the lab is not looking for all of them. So it's only saying that the result is normal for this sickle screening, that the child hasn't got the 5 or 6 unusual hemoglobins that we are looking for. Then if you get a result that says, so the FA evidently is a newborn baby because it's still got a lot of F. AF means that's a child that's a little bit older. So the newborn screening will test children who move into the country who've not been tested before if they're under a year old. So if you get a result that says AF, it means that child is not newborn, but it's still under a year old, and that's why it's being tested. So the result is normal for the age of that child. So that child may be a few months old or what have you. But remember, this is not testing, is not looking for beta thalassaemia, but it does pick it up on majority of occasions. So when they're reporting the newborn results, you'll get HBFAS, which means that that child is a carrier of the sickle gene. FAC, the child is a carrier of a C, AD, AE, and so forth. You'll notice there's an A present, which means this child is a carrier. It's a healthy carrier. So this child hasn't got a disease. It's a carrier of the unusual hemoglobin. Where you get a result and there's no A present, it suggests there's some sort of disease present. So if you get a result saying the child has got FS, because at this early stage, FS usually suggests that the child has got either sickle cell anemia, sickle beta thalassemia, or sickle hereditary persistence of fetal hemoglobin. Unless one knows what the parents sorry, excuse me. Unless one knows what the parents' result is, one cannot determine whether this child has got any one of these three. And the child will need to be retested to confirm the diagnosis when the child is a few months old. FSC, FSD, and FSE are more straightforward. It means the child has got sickle hemoglobin C disease, sickle hemoglobin D disease, and sickle hemoglobin E disease. Collectively, all these are called sickle cell diseases. So the only one that's called sickle cell anemia is hemoglobin SS. All the others are just types of sickle cell disease. So where you get a result that says the child has got F only, there are possible indications for that. Either the child is premature, it's a premature baby, and therefore it hasn't made sufficient adult hemoglobin for the lab to be able to measure it, or the child has got possible beta thalassemia major or beta thalassemia intermedia, or it's inherited hereditary persistence fetal hemoglobin from both parents. In other words, some people will inherit a genetic mutation whereby they don't stop making large amounts of fetal hemoglobin. And these are the people who say have hereditary persistence of fetal hemoglobin. Or the child has got a novel mutation that nobody actually knows what it is. And it's inherited a novel mutation from both parents or from one or the other parent. The policy that we have in the screening program is if a newborn baby is going to be admitted to ITU, we must, sorry, I need my battery. If a child is going to be admitted to special care baby unit, that child must have their sample taken as soon as they arrive in SCBU. That's because you have to be sure that child's result is not from the transfused blood. So, but if the child hasn't been transfused before they've taken the blood spot, then that child, they'll have to do DNA analysis on that child's sample instead to rule out sickle cell disease. As I said, by the time you reach a year old, you've got to switch over. So if somebody's got the normal combination, they've inherited A from both parents, their report will come back as AA. If they're a carrier of sickle, they'll come back as AS. A carrier of hemoglobin C, they'll come back as AC, AD, AE, A beta thal, and so forth. You'll notice now we can pick up beta thalassemia carrier after this early stage. So once a child is over a year old, it's easier to identify beta thalassemia carrier as well. I just mentioned this very briefly, even though this talk is really more about sickle. But if somebody's got the normal beta gene, then they've got beta A. And there are different levels of being a beta thalassemia carrier, right down to having beta thalassemia major, which is where somebody doesn't synthesize any normal hemoglobin A at all. In this scenario, in the beta pluses, they do make a small amount of hemoglobin A. That's because the thalassemias are to do with synthesis mutations, whereas the sickle is to do with quality. These are to do with quantity. So who are the groups at highest risk of these conditions? It's people of Northern European origin and those whose origins can be traced to Africa, Caribbean, Mediterranean, Asia, Middle and Far East. So, but we have to remember there's an increase in intermarriage between various ethnic groups. When we started screening back in the 70s and 80s, we were only screening Black people because as far as we were concerned or aware, it only affects Black people. Then in 1989, we started the comprehensive newborn screening program where we were testing all babies irrespective of their ethnicity. And we realized that, you know, there's a lot of, including non-Northern Europeans with unusual hemoglobins, because we have to remember there's been increasing intermarriage of various groups in the world, and therefore became increasingly difficult, particularly in areas like London and major city areas, where it becomes very difficult to be able to ascertain whether somebody's potentially at risk or not, just based on their color or just based on their ethnicity. So newborn screening, when we then decided we're making decisions about newborn screening back in 2002-03, we realized that we cannot base it on selective testing. So that's why now we have the national program is all babies in England are, and now Scotland and Wales and Northern Ireland, all babies are tested for sickle cell disease, not based on their ethnicity. So in terms of the carrier frequency of these genetic mutations, this gives you grid gives you an idea of the population frequency. Beta thalassemia, the highest population that you see it, the genetic carrier in, is 1 in 7 of the Mediterranean population, followed by Asians. But you'll notice that it's literally in most populations of the world, including the white British, where you've got 1 in 1,000 carriers of beta thalassemia. Sickle is more common in your West African population. In Gabon, it's 1 in 3. They have the highest rate, and then followed by the West African countries of 1 in 4. But you do see it in other parts of the world. So this grid gives you an idea of the different carrier states of these unusual genetic mutations. In the UK, haemoglobinopathies are now the commonest occurring genetic disorder worldwide, and in the UK. Even more common than cystic fibrosis or congenital hypothyroidism and phenylketonuria. We have approximately 350 babies born each year with sickle cell, some form of sickle cell disease. So I won't go into that because it gets so when we talk about the inheritance pattern, if you've got 2 parents and they both have the normal hemoglobin AA, then each time they're expecting a child, they have a 1 in 4 chance of always having children who are AA. So in other words, because they only have hemoglobin AA, their children can only inherit hemoglobin A from both of them. So they will not have a child who has an unusual hemoglobin, unless that child makes its own mutation, because we have to remember, all these mutations started with somebody. But it's very, very rare for somebody to develop a new mutation. I've been in this field now about 30 years, and I've only ever come across one case of somebody who developed a new mutation, and that was when I was back at King's in the early 1990s. So it shows you how, you know, rare it is for somebody to develop a new mutation, but it does happen, which is why we have to be very careful when we get results that are, you know, inconsistent with the parent's result, not to start jumping to conclusions immediately, because anything can happen. If you've got one parent who has normal AA and the other one is AS, then there's a 50% chance the child could have AA like one parent, or a 50% chance the child could have AS like the other parent. And that's with each and every pregnancy. It's like throwing a dice. You don't know what number you're going to get. So every time this couple throw a dice, the child could be any one of these 4 combinations, or 2 combinations, so to speak. But if both of them are carriers, then there's a 1 in 4 chance the child could be AA, a 2 in 4 chance the child could be a carrier, AS, and a 1 in 4 chance the child could have sickle cell anemia, SS. Again, that's with each and every pregnancy. Similarly, AS and AC, the child could have SC. which is sickle hemoglobin C disease, which is a form of sickle cell disease. And similarly, beta thalassemia, the child could be a carrier, could have the normal combination AA, beta thalassemia carrier, AS, or sickle beta thalassemia disease. So when we look at the family tree, this is just to give you the same scenario I showed you earlier on. So these are how the chances work. Each parent can only give the child one of their hemoglobins, and it has to combine with the other parent's hemoglobin in order to determine the 4 possible chances. So, what is sickle cell disease? How do we deal with sickle cell disease? Sickle cell anemia is the most common type of sickle cell disease, and it's often the most serious. Then you've got sickle beta 0 and sickle beta thal, plus thal, sickle hemoglobin C disease, sickle hemoglobin D Punjab, and sickle hemoglobin E or other combinations. So there are different types of sickle cell disease. But like I said, SS is often the most common and the most serious of the disease. This is not a comprehensive list. Remember, I said there are over 1,200 mutations of hemoglobin. So if a person inherits an S from one parent and another unusual mutation or genetic mutation from the other parent, they've got some form of sickle cell disease. The problem with sickle hemoglobin is that the hemoglobin molecules within the red blood cells, they stick together to form these long, stiff rods. And as they form these long, stiff rods, these push against the membrane of that red blood cell and cause it to become distorted. And that's where you get the odd shapes of sickle occurring. The unfortunate thing with those long, stiff rods and the red blood cells is that they can't traverse the circulation very well, but I'll talk about that in a moment. So the problem with these sickle red blood cells is they only live 5 to 10 days instead of the normal 120 days of a normal red blood cell. They become hard and rigid and brittle, and they can't travel through the blood circulation, the veins, very well. So they cause blockages. I won't go into, so you get that the main issue that causes this problem is a genetic mutation on the chromosome. So on the 6th point of the beta globin gene, there's a point mutation. So instead of the globin chain, the globin chain being glutamic acid, it's changed into valine and lysine and what have you. So valine result in S, lysine result in C, and so forth. So it's just point mutations on the globin gene. Newborn babies with sickle cell disease, they don't tend to present with symptoms because the fetal hemoglobin does not sickle. So you'll find majority of them will not have symptoms until they're about 3 months to 6 months of age. And some may not even have symptoms for, for the first few years of life. Even when most of the fetal hemoglobin has diminished, some may not have symptoms. And that's why some children, particularly in other parts of the world, are not, parents don't realize that the child has got sickle cell disease unless they've been tested. Complications is very rare in children before the age of 3 months, like I said. So they rarely have crises or anything like that before 6 months. And a third of children will develop symptoms by their first birthday and 2/3 by their second birthday. So any state where there's hemoglobin S and no normal hemoglobin A or very, very diminished hemoglobin A, the red blood cells will change into those crystallized shapes. The hemoglobin within the red blood cells will all aggregate. They form long rods called tactoids, and these, as I said, causes a misshapening of the red blood cells, and these can cause blockages, and these are what results in what we call the vaso-occlusive sickle cell crisis, which is the hallmark of sickle cell disease. Evidently, where there's hypoxia, tissue anoxia, then you get tissue damage. They get chronic hemolytic anemia, because that's why we say it's very important to realize this is not the same as iron deficiency anemia. This is a hemolytic anemia because their red blood cells is not living long enough, so their red blood cells get broken down very quickly. As a result of blockages in the spleen gets very damaged because these red blood cells, they have these little sharp ends and what have you that can damage the lining of the spleen. And we all remember that the spleen is there to help you develop immunoglobulins and develop your immunity. But children with sickle cell disease, their immunity is poorly developed because their spleen gets very damaged from a few months of age, from very early on in life. So as a result, they get immunocompromised and they can't fight infection very well. So this is just to depict the blockage. If you look at the picture at the top, this is the normal red blood cell. It's able to flow freely. Even when it's deoxygenated, it retains its normal shape. But when you've got sickle red blood cells, where there's deoxygenation, once it's deoxygenated, it changes into a sickle shape. And then it has problems trying to travel through the blood vessels. When it gets back to the lungs, it will unsickle. But after repeated sickling and unsickling, it is no longer able to unsickle, and it becomes what we call irreversibly sickled red blood cells. Now, where these blockages occur is what we call, that causes a pain because there's no oxygen going beyond a blockage, and that's where you get vaso-occlusive pain, a vaso-occlusive crisis or sickle crisis pain. It can be varied in terms of the severity of the pain. The pain could be mild, moderate, or severe. Majority of patients manage mild and moderate pain at home. It's only when it gets excruciating that most of the medications they're taking can't manage the pain. That's when they will tend to go to hospital. So pain is the hallmark of sickle cell disease. I've mentioned already about compromised immunity, and pain is another major problem for people with sickle. What are the things that contribute to sickling vaso-occlusive crisis? Things like hypoxia, acidosis, dehydration, and infection. Dehydration and infection is one of the two top most common causes, especially in children. Temperature changes. We all know what happens when your body's cold. You get vessel constriction. So these cells are more likely to cause obstruction where the blood vessels lumen, the middle of the blood vessels is narrowed. So sudden temperature changes. And of course, any physiological additional demand or stresses on the body, for example, pregnancy, people are more likely to have crises during pregnancy. This slide is very busy, but I don't expect you to go through the whole thing. But basically, just to show you some of the potential complications, clinical complications associated with sickle cell disease. So anywhere in the body, literally, where there's blood, you can get sickling complications. So you can get enlargement of the heart, like cardiomegaly. You can get, particularly for people with HBSC, you can get eye problems as a result of sickling in the eyes, and also the blood vessels in the eye get disrupted. So you can get involvement of the spleen. This can be a major problem, especially in childhood. There's slight reduced fertility, and all sorts of various problems associated with sickle cell disease. That just gives you an idea of some of the complications that can arise from sickle. So for most people, we say, swimming in cold water causes vasoconstriction. You'll find people, particularly in the tropics, when it's they say they have more crisis during the rainy season because they get caught out in the rain. Their blood vessels constrict because of cooling of the body, and then they end up in crisis and end up in hospital. So, various things in the temperature can affect how one copes with this. Stress. We all know that the mind has an effect on the physical. So you'll find some children, if they're being bullied in school, for example, or they're having exam pressures, family stresses, all these things can trigger a sickle cell crisis. So we have to remember, sickle cell is not related to color, nor any of these unusual hemoglobins. even though you see it more in certain races of people only because of the area of the world where they come from. I always like this quote because this is a woman, this is somebody in the States. She says, sickle cell can affect any race. My husband and I are a Caucasian couple with 2 boys that have sickle beta thalassemia. One is Italian and she's Italian and she has thalassemia trait, and her husband was discovered to have sickle cell trait, and they were quite surprised because they were blonde and blonde and blue-eyed. Her husband was blonde and blue-eyed. So there's still a lot of misconception about the inheritance of these unusual hemoglobins, but it's to remember we have to take account that it can affect any race in any society, in any population. So no, hemoglobinopathy is exclusive to any ethnic group. All persons are theoretically at risk of carrying a hemoglobin mutation. Okay, I will stop there. And this just gives you some resources, websites that will be useful. And thank you for listening. Over to you, Ralph.
Thank you, Lola. That's really appreciated.
Time to wake up, Pamela.
I have sickle cell anemia, which is one of the sickle cell disorders.
Okay.
The difficult thing to understand about my condition is the fact that there are no visible signs. So if I say I'm in pain, it's like, where? it's I think sometimes when you don't see something, it's very difficult to believe it. And having a blood disorder, like my condition is, it's so you can't see anything because it's in the blood. And even when you are in a lot of pain, because there's nothing really visible, it's very hard for people to grasp. I think the most distinctive thing about my condition is the way it can be so unpredictable, because I can wake up and feel great, or I can wake up and I'm not really sure how my day is. I can wake up and feel really bad, or I can go to bed feeling great and wake up feeling in a lot of pain. It's just very unpredictable. Sickle cell, it's genetic, so you can't catch it. And I inherited it from both of my parents. My mum and my dad are both have sickle cell trait. So I inherited sickle cell disorder because of their genes. And what it does is it changes the shape of your red blood cells. So whereas most people, their red blood cells are round, mine are crescent shaped or sickle shaped, hence the name. And because they're shaped, they can get caught amongst each other when they're in small capillaries. So as your blood is flowing, they can get stuck together. And also the sickle cells are more sticky as well. So it's difficult for them when they are all clumped together to release. And what this does is it causes my body to have a lot of pain. And this can occur in any part of my body and at any time. Having blood transfusions reduces the amount of sickle cells that I have in my blood. The place where I get pain most frequently is my hips. But when I get pains in my long bones and my shins especially, it's a lot harder for me to deal with. It's just very intense, very painful, very sharp. It's like it's under somewhere and you can't dig it out to deal with it. And it just feels like a gentle hammering that kind of gradually builds up till you just can't take anymore. It feels like there's a pressure point and it feels like you're gonna snap. It's really horrible, but it does feel like you could just snap. When I have a bad day, it's very difficult actually. I have to stay at home.
Bye, everyone. Bye.
At times, especially like during the school term, I just, you just think about all the things that are going on, how much you're going to have to catch up on. My average, my average school attendance is about 60%. So I'm now 2 years behind going to uni. And the hardest thing for me is when I'm at home and I feel really ill, but I can't do my schoolwork at home. And that, I always feel guilty. It's hard to see where everybody else is going and you being held back. That's something that's really difficult to do. I think what I wish everyone to take from me being on this film is just the fact that I really want to be believed, and that it doesn't look like I have anything wrong with me, but I go through a lot.
Okay, Bianca.
Yes, I was just wondering, with the pain involved, would you recommend just taking pain relief for patients with severe pain?
Well, they do. They have different levels of pain relief. So anything from paracetamol, or in children, sometimes they'll take ibuprofen as well. Anything up to as high as opiates. Evidently, that's why I said they have mild, moderate, or severe pain. When they're in severe pain, they then need to go into hospital where they do get, morphine.
Okay.
Yeah.
Good afternoon. My name is Vesna Graham, and I'm the community specialist nurse working for Ealing Community Partners. So this afternoon, I'm it's going to be a brief talk about the care and management of children in the community. Next slide, please, Ralph. Sorry, Ralph.
It might just be taking time to load, Vesna. Can you see it now?
Yes, I can see. Okay.
And now you need to mute your microphone.
Okay.
So currently in the United Kingdom, all babies are offered testing via the newborn screening program. So this is a blood test, and it is done between 5 to 7 days following birth. And all babies, if children are tested for their hemoglobin type. So if the test shows that the child has got a positive result, it's either they're going to be a carrier status, and that is carrier status simply means that the child has inherited, say, sickle cell trait. The parents will be informed either via letter, or they would receive a visit from one of the specialist nurses and or a health visitor. If it is a confirmed sickle cell disease, parents are informed by 28 days of the result. But usually it's done a lot earlier, because the specialist nurses from the Brent Sickle Cell Center will inform the parents. They will visit them at home to give the result. And it's usually done pretty early, probably between about 5 days of them actually receiving that result. And what they do is, obviously, when they visit the parents at home, is basically to explain what the result means for the child, and also to explain the care that they will need to, that the child will be offered. All children, if they've got a confirmed result, they will be registered in their local hospital by the time they're 8 weeks old, and they should be seen in clinic by 12 weeks of age. Next slide, please. So once a child has been diagnosed as having sickle cell disease, there's certain things that needs to be done. And one of those things is that a child should be given prophylaxis penicillin. Now, It's penicillin V, and if they're, say, for instance, allergic to penicillin, they should be offered another type of antibiotics, and it's usually one that is erythromycin. But the vast majority of the time, the children on penicillin seems to be okay. Now we start at 3 months with a small dose. It's 62.5 milligrams, and it is given twice daily. When the child reaches a year old, it will be increased to 125 milligrams, again twice daily. And at 5 years old, it will be 250 milligrams, and that is the dose that they will remain on through childhood, and of course when they're in adult, when they reach adult as well, they will continue to have that dose. It won't be increased any further. They'll also be given folic acid. Now the folic acid, as Lola mentioned before, the folic acid helps the bone marrow with the maturation of new red blood cells. This is because with normal red blood cell lives for about 120 days, but with the sickle, they will only live for about 5 to 10 days. And so we need to enable the bone marrow to mature these red blood cells more quickly so that it can be released into the blood circulation. And obviously they will need to continue on folic acid throughout their life also. Now the other medication that we use would be Pneumovax. Now the Pneumovax is all babies are now given Prevnar at birth, but at the age of 2 they need to be given Pneumovax vaccine, and this is because Prevnar will protect against 13 strains of pneumococcus bacteria, but the Prevnar will protect against 23 strains, and so it is given at age 2 and again every 5 years thereafter. In the new system now, we used to recommend the hepatitis B, and we do want our children to have hepatitis B, but it's now part, since August, it is now part of the childhood schedule anyway. So all children are now getting the hepatitis B as part of the childhood recommendation. Next slide, please. So when we see parents at home, what we're trying to do, what we're doing is to educate the parents and of course patients about their condition. So we will talk about the inheritance, ensure that they know how it is inherited, and that that both parents have to be carrying a trait for the child to have inherited the full-blown condition. We'll talk about how they would recognize the signs and symptoms of a sickle cell crisis, and knowing when to seek medical help. Now, with babies, it is very difficult, obviously, having a new baby to know when a child has actually having a crisis. But, you know, with all babies, it's the means of them communicating to their parents. So if a child is crying, you've done like feeding that child, you've done everything that you know a parent should do, then it is a possibility that that child obviously is not feeling well. It may not be a sickle cell crisis, but they're obviously not feeling well. But one of the things that we ask the parents to look out for is what's known as dactylitis. So it is swelling of the hands. It could be just one finger, or it could be both hands, it could be one toe again, or it could be both of that child's feet. To look, if there is swelling there, it means definitely that that child is experiencing some form of experiencing a crisis. We also show parents how to palpate for the spleen. So The spleen, as Lola mentioned before, it filters the bloods, and sometimes the spleen can become, when the blood flows into the spleen, the exit can become blocked with the sickle blood cells. And of course, at that stage, the abdomen becomes distended, it is painful, and then you'll be able to feel the spleen under the left rib. So we will show parents how to feel for the spleen, and obviously if they can feel the spleen, that you get in touch with us, and a child will be given an appointment in the hospital urgently so that we can monitor it. We also talked about, because there's possibility that some children can actually have a stroke. And so for parents, obviously, or whoever is caring for that child, to be vigilant. Sometimes it is the one that can be seen, you can see it's just like an elderly person who actually, has a stroke. So they'll be leaning on one side, they'll not be able to walk and things like that. But sometimes it's not so obvious. Sometimes it's very subtle, and things like, for instance, you have children who may be used to use the cup with their right hand, for instance, and are no longer able to use it. They start using their left hand, and so you have to query as to why a child is not using the right hand, and things like that needs to be mindful of. We also talked about if the child has a cold, it's sounding chesty, it's important that they take the child along to their GP so that they can listen to the chest to make sure that the child has not got an infection, chest infection. If they have a chest infection, they would need to be given antibiotics. Also, the temperature. Keep an eye on the temperature again, because that's an indication that the child may have an infection and so need to be treated promptly. In boys, we will discuss priapism. It is painful erection of the penis. So, and it can happen in small, very small children as well. If things that we would advise, maybe walk around, have a bath, to do something distraction. If the pain is continuing for quite a while, we say more than 2 hours, then they need to seek medical help straight away. We talk about health and lifestyles. I have already mentioned about prevention of infection and that taking their penicillin. Smoking also, because smoking lowers the oxygen level in the blood, and again, that is, they may end up having a crisis with that. Alcohol consumption causes dehydration. Prevention of dehydration. So we advise that you should drink at least 2 liters of water in 24 hours. So it doesn't have to be, that's in addition to drinking things like tea and, well, obviously children, other drink fruit juices. So water, at least another 2 liters, that's in addition. To avoid stress, and this is usually mainly during examination time, when children are having their GCSEs, they become very stressed. A lot of the time when adolescents end up in a hospital, it's usually around about the time that they're having an exam, because they're so stressed. It's very difficult, but the only advice that we can give for that is, to be consistent and obviously to work, do their homework, and try and study at a normal pace. Appropriate clothing. So you need to be dressed appropriate for the weather. So if it's very hot, then obviously you wear loose clothes that will keep you cool. And if it's in cold weathers, to make sure that that person is wearing clothes that is going to keep them warm. And with very cold weather, what happens is that if we're cold, what happens is that we shiver, and when we shiver, the lumen of the small capillaries gets very small, remembering that these red blood cells are changing all the time. So when they change, if the lumen is much smaller, it is much more likely to become stuck in the capillaries. Obviously, when they change their shape, they're also sticky, so it's much more likely to become stuck in that environment. So we do advise that they wear appropriate clothing. Next slide. With pain can be mild, it can be quite moderate, or it will be severe pain, depending on what the pain is like. So for home medication for children, we would advise taking paracetamol or ibuprofen, and for adults it will be much more like codeine, phosphate, and naproxen or cododramol. If the pain is really severe, then they need to be admitted in hospital, and we'll use opiates for that. Now, there's other intervention that you can take, such as psychological interventions, like cognitive behavioral therapy. So, we'll advise to use like distraction therapy. So if a child is in pain, you've given some medication, so maybe they could watch their favorite Disney cartoon, or listen to their parents telling them a story. But one thing not to do is to leave that child alone, because the pain will then obviously escalate if they're frightened. So if there's someone with them, keeping their company, talking to them, distracting them, hopefully the pain will subside with the medication that they've given them. There's other complementary therapy that can be used, such as the TENS machine, massage, or having a warm bath. Next slide, please. So in primary care, what we it's like for teachers, health visitors, and school nurses, things that we'd like them to do is to be aware of the signs and symptoms of the sickle cell crisis and how they can prevent it, such as in school. For instance, ensuring that the child is wearing, if you have a small child, ensuring that they're well dressed, wearing their coats, for instance, if they're going out into the playground. Be able to have water available for them to drink, and if they're drinking a lot, they will want to go to the toilet more frequently as well. So, make it easy for that child to go to the toilet. Also, sit away from drafty windows. I know in this environment now is that they're asked to keep the windows open, but to try and sit the child maybe somewhere that then won't be cold, and obviously allow them to wear extra clothing in school if they're feeling cold, in their classroom if they're feeling cold. Ensure, you can ask the child, are they taking their medications? And how often are they taking it? Ask about their immunizations, because all children, we do advise that they have the flu vaccine. So this is one of the things you could, primary care can ask if they have had the flu vaccines. They can monitor their absences from school if they're not in school, and make preparations, because obviously when they're admitted to hospital, if they're ill, they're away from school. And so, make preparations, ensure that, they're given their lessons and extra help once they've returned to school. And encourage other members of their family to have a test done to find out whether or not they're at risk of having a child with sickle cell disorder. Next slide, please. Next slide, please. We do offer social and psychological interventions as well. So one of the things that we would discuss is choosing a career pathway. So people with sickle cell disease obviously need to choose a career that they're not going to be sort of outdoors, you know, not working in places like, and this, you know, doing road works in cold weather, working in Iceland and things like that. They need to be like in an office job, something that they'll be able to keep warm. Obviously, there's nothing preventing them from having been a doctor or a nurse, but things, but career that they, you know, obviously they're out of the cold all the time. They're in the cold all the time. Relationship and marriage. We offer pre-conceptual counseling, so you know, so that the adolescents they know their hemoglobin type, and obviously they need to find out the type of hemoglobin that their partner has inherited prior to starting a family, ensuring that they have the right contraceptions, and attend family planning. One of the contraceptions that is used is Depo-Provera. Depo-Provera was shown that in Jamaica that it helps to reduce sickle cell crisis. So that is one of the contraceptions that we do, that people with sickle cell can use. And obviously prevention of infection. So the infection that I'm talking here is SCD, so use of a barrier method of, you know, contraception before, obviously before their marriage. We talk about travel, that they should be fully immunized before traveling. So going to a country that, for instance, you know, yellow fever, and especially with people who have got sickle cell disease, is one of the, you know, Lola mentioned it before, is areas where you have malaria. So if they're traveling to a country where there's malaria, they must ensure that they do have their anti-malarial immunization, and it is not advisable for them to travel if they have not had their immunizations. We also advise insurance. Ensure that they, you know, especially if you're traveling to a country like America, you need to make sure that you have appropriate cover. One of the things that they can do is carry also some information, you know, of the type of treatment they've been having, like their current clinic letter would also help, should in case they become unwell. Next slide, please. Other things we do is we do referral to housing departments. So because the type of environment that that person is living in has a lot to do with their health. So if they're living in cold, damp, moldy condition, it's a risk of infection, and they're much more likely to have sickle cell crisis. We do offer social care as well. So we help with DLA or PIP. So DLA will obviously help, you know, sometimes patients are not, because of their condition, they have problems with walking, etc. And so DLA, for instance, would help them maybe to get a mobility car, will help them to be able to travel to their appointments and get around more easily. We also talked about voluntary organizations such as the Sickle Cell Society that may be able to offer them some help, and of course the patient support group, which is always, you know, good for patients to get to know other people who have also inherited the same condition. They'll be able to be a support for each other. Next slide, please. Currently, for specialist therapies, we do offer patients hydroxycarbamide. So most people might hear of it as hydroxyurea, and we do recommend it for children. It helps to reduce the sickle cell crisis and obviously organ organ damage. We offer it to all our patients, even small babies, we do offer it now. Obviously, it is offered, so it's not something that we force onto anyone. Blood transfusions, we use blood transfusions. So blood transfusions, people who've had a stroke, if they've had recurrent splenic sequestration. So splenic sequestration, I mentioned earlier before, is when the spleen become enlarged, the hemoglobin level falls rapidly, and in that can be fatal in small children. So we do, if they're having recurrent splenic sequestration, we recommend blood transfusion. We use it for people who are having chronic complications such as cardiac, respiratory, and also if hydroxycarbamide has failed or it has been refused. There's other therapies. Obviously, it's not for everyone, which is stem cells, which is done in children, but it's not as yet a standard treatment for anyone. There is a criteria for stem cell for having stem cell, and it's not yet a standard treatment for adult patients. Next slide, please. So I've been through sickle cell disease, so I'm just going to mention very briefly about thalassemia, because if we mention sickle, we must mention thalassemia as well, because this is another inherited condition. Next slide, please. So there's different types of thalassemia. So there's beta thalassemia trait, which is a carrier, meaning that that child or the person has inherited a beta gene from one parent and the A hemoglobin from the other parent. So with this particular, just like with sickle cell trait, it doesn't require any treatment. There's thalassemia intermedia. Lola mentioned it briefly in her presentation. And with this particular type of thalassemia, that child, a person may or may not require blood transfusions. But with beta thalassemia trait, where the child has inherited the beta gene from both parents, that is transfusion dependent, because they're not able to make any A hemoglobin at all. Next slide, please. Next slide, please. So with thalassemia, it causes severe anemia. By the time the child is about 6 months old, their hemoglobin level has fallen quite rapidly. It would notice because the child is failure to thrive, so they're not eating, they tend to sleep all the time. There's maybe skeletal changes, and they're always having an infection. Next slide, please. So the treatment for thalassemia major is blood transfusions. So anyone has thalassemia, the only treatment is blood transfusions. And what you need to do is to correct the anemia. And by correcting the anemia, you enable growth and normal activity. You prevent the enlargement of the spleen and inhibit erythroid marrow expansion. If we give blood, we also give iron, because we're not able to separate it. And so we need to use something, a medication, to get rid of the iron that we are giving, that's in the blood. And we use iron chelation. Most of the time it's used one that is called XJADE. We start using it when the ferritin level is above 1000. Next slide, please. So the complications that we can have from iron overload is delayed growth and puberty, could cause liver damage, diabetes, cardiac impairment, erectile dysfunction, and amenorrhea. Next slide, please. So the pictures just simply show you there is, the child on the left is without any treatment, but the child on the right, if they've been well chelate, this is how we expect that our children should look. Next slide, please. Just a little bit about COVID-19, because recently we've had a lot of calls from parents about their children, and so we are following the national guidelines in that all our children, do not need to shield at present, and so they should remain in school and just follow all the guidelines that is recommended, like washing hands, using their face mask, downloading track and trace, and just to isolate, if there's someone in their, maybe now it's someone in their school or in their home that has got tested positive for COVID-19. Okay, thank you very much.